Yeah, I've worked in a number of organisations under both the Australian health system and the Australian education system. And I think in both systems, this governance has provided a sense of security and a steady flow of funding which has made service delivery possible. In both situations, though, one of the main challenges that I've experienced is that the release of funding is often tied to deliverable outcomes. So if we were machines and input equaled output, there'd be no issue, but humans are dynamic and complex. You could apply the same deliverable approach to 100 different people and you'd get 100 different outcomes. So while funding makes service delivery possible, I think policies can sometimes be a little rigid around outcomes, meaning that organisations are forced into a position of either sacrificing the quality of the intervention to achieve the expected outcomes or delivering highly personalised, nuanced services at the risk of sacrificing the funding. So that's been somewhat of a paradox or a dilemma that I've found in both systems.
Well, I mean, it's really hard, particularly when we look at eating disorders, when on average it's recommended that a course of treatment is 20 to 40 sessions, and per year through the Medicare mental health care system, they get 10 sessions covered. So that's really, I guess, a lot of strain on individuals and on their families. And there's often not the availability in public services for them to get treatment at no cost. So I guess we try and prepare clients at the beginning of treatment and sort of letting them know that this is likely to be 20 or 40 sessions, you're only going to have 10 covered. And at the outset, we're kind of trying to help them prepare for how they might manage those future sessions. So trying to get a bit creative around private health or the Medicare safety net or just trying to think of some ways about how treatment's going to be sustainable for them the whole way through, but it is really difficult for a lot of people. I guess anyone's really sort of chronic or acutely unwell, it's not really, I suppose, it doesn't seem ethical to sort of start treatment and then not to be able to continue. So if in the first session we identified that someone wasn't going to be able to afford ongoing treatment and there was nothing that we could do to support them, we would be looking for what services can we link them in with that they are going to get the treatment that they need that is affordable. So right from the outset would be, I suppose, kind of taking on a case management role and trying to link them in with some of the public services or the not-for-profit services that we are lucky enough to have in Brisbane.
Through the Chronic Disease Management Scheme, which doctors are able to provide a certain amount of allied health visits per year, we're allowed to see clients for up to, let's say, 5 visits for one of the allied health professions. And with those 5 allied health visits, we provide a certain amount of funding to see that patient. However, we may actually require 6, 7, 8, 9, 10 visits to actually make a significant difference in somebody's health. So to be able to work with 5 visits may be quite tricky. So you need to do the best you can as a clinician to work within those funding arrangements to be able to deliver the outcomes that 1, the patient wants, 2, you expect, and 3, the doctor wants. So there can be quite a lot of expectation placed on you to be able to deliver services within the funding available. There's not an endless stream of money there. And even no matter how much somebody wants to change and how much they like seeing you, if you get to the end of that bulk billed visit, if you as a clinician decide to bulk bill, and you ask that patient, it's going to cost this much to see me at the end. If they don't have the money, they don't have the money, whether they're spending it on alcohol or smokes or whatever they are. If they're not willing to give up some of that stuff to have the money, they're still not going to come see you, even though you're making a difference in their life. So you need to understand funding parameters and what's the biggest, most important changes that you can make in somebody's life and get those started straight away to actually make significant change and difference.
So working in the public hospital sector, there is a lot of governance and responsibility and accountability for finances and resources. Being funded by a state healthcare model, a lot of our funding is from our state taxpayers. So there is an expectation, not just from the organisation, but as individuals, to be responsible for how we use medicines, how we're prescribing medicines. Obviously our priority is to promote best outcomes for patients through the use of medicines, but we also want to make sure we're having a due diligence to the state by minimising wastage and balancing the promotion of best quality of medicines, but also preventing wastage as much as possible. So in my day-to-day job as a pharmacist in a public hospital, we have to adhere to a list of approved medicines. It's a wider committee has agreed upon set medications which can be prescribed and given to patients. That kind of balances all of those aspects, and so part of the role as a pharmacist is to make sure that prescribing is in line with that list of medications and that we're promoting those factors in day-to-day care.
The care that we give is still the same, we just don't have the time to stay there and educate you as much as we'd like. So one of the main things I notice is in the public wards especially, they stay for fewer days, so the length of stay in total is less, which means you simply can't get all the information into 2 days versus 4 days, you know. So I find that those women then go home with feeding issues, so then they show up to their Child Health, which is a Medicare funded initiative. So they show up to Child Health with all of these breastfeeding, sleeping and settling issues, which then puts more strain onto the public health system. So it's things like that that sort of flow on and you don't realise at the time until you step back and go, oh, hang on a minute, we've got heaps more women presenting in the public system versus the private. And it's purely because they didn't get that education initially.